All right, we're all set.
Okay, thank you, and welcome to the Insurance and Pharmaceuticals Subcommittee of the House Government and Operations Committee. This is where we discuss the bills to try to get them ready to take to our whole committee. We are bringing some bills back today because there's been some work on them since our last meeting, and we're hoping that we're very close to moving these bills, and we will have a discussion about 3 bills today. They're House Bill 912, House Bill 974, and 1219. We're going to go in that order. We're going to begin with House Bill 912, which is Health Insurance Panels Coverage for Non-Participation. Real quickly, Lisa, would you remind us what the bill does and what the amendments do? I know Lisa's here someplace.
Yes, I'm here. Okay.
There she is. Okay.
House Bill 912 requires carriers, except for managed care organizations, to cover mental health or substance use disorder services provided by a non-participating provider at no greater cost to the member than if the services were provided by a participating provider under specified circumstances. Carriers must also inform members and beneficiaries in plain language of the process of requesting assistance and finding an appointment. And the Consumer Education and Advocacy Program must provide public education to inform consumers of the process. There are amendments on page 2 of the packet that was circulated that clarify that the plain language requirement convey the information to members and beneficiaries for them to contact their carrier for assistance in finding an appointment. The amendments require a carrier to ensure that mental health and substance use disorder services received from a non-participating provider should be provided at no greater cost to the covered person than if the covered benefit were provided by an in-network provider. They strike language requiring the Healthcare Commission to establish a reimbursement formula for non-participating providers, and they add a 3-year sunset.
Okay. Delegate Sample Hughes, would you like to speak to these amendments? I know you have another one too, but if you want to start with these amendments.
Sure. The goal is still the same, as the committee is probably aware, that we're trying to make sure that persons who are in need of these services are not walking away with a high cost to just receive those services from out of network. And so with the amendments, we made sure it was specifically important for the consumers to be informed of their rights, as well as the information that they could use in the education program, just as it was noted. And that particular advocacy unit of the Attorney General's office will provide that public education. The other area that we wanted to ensure the change of amendment is that no greater costs would be incurred to the person who is in need of these services. So that's the amendment number 2 that is on page 6. Then, and I don't know if I've seen it yet, but there was an effort to make sure that the MIA was a part of this process. Is that in there, Lisa, as well?
Is it what? I'm sorry.
The MIA having the requirement to conduct a report on the credentialing reimbursement, as well as how long it takes for individuals to, for carriers, providers to get into the network.
All right, that part is not here.
No, it's not there.
Okay.
Okay,
Yeah.
that's one that
Okay, good. Thank you, Delegate.
needed to ensure that was in there as well.
Okay, so we will, would the committee accept a conceptual amendment that says the MIA will report to us on the
It could be,
the credentialing process and timeline, and the network and how the development of network is happening. And Delegate, I think there's something else.
yes, so it was how long it takes for a provider to get into the network, the credentialing, and any reimbursement that has to occur. Those were the three items.
Right.
And
the impact on reimbursement.
The impact on the reimbursement. And the goal behind that was twofold, because our committee have heard over the years how difficult it is to get into the network for some providers, and some effort to have that done has taken 6 months to a year for a provider to get in. And so with that being said, this data, this information will help show the grander picture of what we are grappling with, and how we can, through policy, effect change and get these get these providers into the network if they so choose. The last thing that I'll highlight about amendments, and I just want to double check that was in there. We had also mentioned about the boards, of whether or not they would be able to provide the names of providers, so the insurance companies could be able to reach out to them as another way to get the names of entities that could potentially come in the network, or at least doing some outreach.
Right. And we did, there was an intention for it to be here that, but I'm going to look at Delegate Kelly for a moment. The issue is that the carriers know who the practicing providers are for mental health services in Maryland. The boards have that information, all of the mental health boards. And know that you are working on something similar in your subcommittee, but was there any issue with us including it here, saying that the appropriate boards would provide information on practicing providers who have not opted out of that? I would assume that
I think that the devil is in the details of the language. I think conceptually there's, great agreement that we both need to do that and should be doing that. I think what we would hear from the boards is each board has a different process and different limitations. And this has been an ongoing challenge for them for the last few years to comply with this request. I'm not opposed to putting it in a statute, because they are more than aware that this is something that we need to be figuring out how to do. I wouldn't make the language too prescriptive, because they need to be nimble and figure out how, each board needs to figure out how they can do it in a different way.
Okay. What I would like to do, if this is okay with the committee, if we can approve the amendments that we have and discuss the last amendment, know that we're going to work on this during the day, and after the Health Occupations Subcommittee, we will come back with the language on the board language and the MIA report. So just be prepared, those of you who are on health occupations, you're going to, transfer over to insurance and pharmaceuticals right after. And we'll try to wrap that language up today. So that
Madam Chairman.
Delegates.
Thank you. I just have a quick question. So I know there has been a lot of discussion, and I think from the insurer's point of view, and I'm just trying to figure out, so when people, because some people say there is enough, and there isn't network adequacy, are those members required to call their carrier first before they go out of network? Is there something, maybe we can add some sort of language, at least they make the effort before they go out of network, so it doesn't create any issues, which is a different way of it's not really, I guess, if it fits in this amendment, but do we have anything that before anyone can go out of network, at least they make the attempt to call the carrier first?
There's nothing specific in this bill that does that. However, in the area of informing members and beneficiaries in plain language, that and providing the provider directory, it says they should contact their carrier for assistance. Is that strong enough, or you need something stronger than that?
Well, I mean, do they have to prove, I guess, that they've contacted the, I think it should be more spelled out, just so there's no gray area. So at least members know that they should do that before. So I would maybe tighten it up a little bit more, just so it's clear.
Okay, I'm gonna go to David Cooney from MIA before I go to the other questions. David, do you have a comment on this specific piece?
Yes, thank you, Delegate Collison. I just want to address Delegate Saab's concerns. The existing language requires the consumer to request a referral to the out-of-network specialist. So under the existing law, they can't get it unless they actually go to the insurance company and request it. They can't just self-refer.
Does that answer your question, Delegate?
So that's this is currently in the law
In
that
current statute.
they can't.
If you look at subsection D on page 5 of the bill, it kind of outlines the process that the carriers are required to develop. I guess each carrier might have a little bit of a different process, but they're each required to have a process where members can make requests to see out-of-network providers.
So, but when they call to help and say, I need a request, do they ask them to help? I guess the question would be, maybe ask the carrier first to help them find someone else in network before they go out of network, because that's ultimately is going to end up costing more of some sort. So I guess the language that I was thinking is maybe ask them to ask for permission, which is already existing law, but also go further and request help. And then at that point, if the carrier can't find someone, then obviously they're going to have to approve the.
I mean, I think that's partly what the bill is doing in the amended language.
Mhm.
It's requiring the member to contact the carrier and ask for help making an appointment.
Yeah, I think
But making an appointment with an out of network, but not making an appointment with an in network.
no, to make an appointment for an in-network provider first. That's what, that's what's intended here, that they,
Okay.
the member would do that. And then they would have to, in order for them to not be subject to additional costs, they have to have followed that process.
Yeah, maybe Deb can chime in then. I don't know. I saw her shaking her head, but like I said, I was just trying to clarify it. Thank you, Madam Chairman.
Okay, thank you. I'm going to go to the committee members before I go to the advocates. Delegates Krebs.
Thank you, Madam Chair. I had a question about handwritten page 7, line 6, number 2, and just wanted to see what the carriers had to say about this. The carrier shall ensure that services rendered in accordance with subsection D, blah, 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 are offered and provided at no greater cost to the covered person than if the covered benefit were provided by a provider. So I just want to know how that would work and if they're okay with that.
So I'm going to go to Kimberly Robinson, since this she provided us with this, helped us out with this language.
Okay, that's fine. If they're okay with the language, I want to make sure.
Thank you, Delegate Collison, and thank you for the question, Delegate Krebs. I think, the concerns of the carriers just about how we want to be careful that the law doesn't create a scenario that overly encourages non-participation remains. But we do have some experience with the language as it's drafted from other states. So you heard a conversation earlier on this bill about what other states do. The bill that was in front of you did not conform to what other states do. This language puts us on par with states who have acted. So a little less than half the country has done something in this area. This is the most common version of that language. It still allows us to negotiate single case rates and still gives us the opportunity to try to work with providers who may be non-par to still be able to see our members who may need their services because there's not an available appointment timely enough, which is often a challenge because people are seeing these kinds of providers on a standing regular basis. It's not like acute care where you only need to see them one time. And so while certainly not our favorite, this language is livable. from my perspective.
Good, because I remember you mentioning that about the other states and the language wasn't the same. So I'm glad you're
Correct.
comfortable with this. That's why I highlighted it. Thank you.
Thank you,
for the
thank you,
question.
Delegate. Okay, I'm going to go with Dr. Berman.
Yes, hi, thank you very much. I just want to clarify one thing. It seems that there's no interest, certainly among practitioners or I think among the committee, to prevent people from going out of the network if they wish to do so. What we're talking about here in this situation is people who want to stay in network, but there are not an adequate number of in-network providers or no one who is available at a reasonable amount of time. So I just wanted to make that point. So I have two concerns with the amendments. One, if I may, is on page 5 of 7, lines 30 and 31, removes the language that the carriers would be required to inform subscribers of the right to request a referral under paragraph of this subsection. Sorry, I can't read it with my glasses. And it seems to me that removing that language, removing the requirement that carriers inform subscribers of their rights to go out of the network and contact the carriers if there's someone not available in network is a problem, because consumers need, it seems to me, be proactively reminded and informed of their rights. And removing that simply puts the onus on the carrier to say the carrier is required to have a plan in place. And I'm concerned about that and certainly would prefer that consumers be proactively informed. The other quick comment, if I may, is I also have concern about removing the Maryland Healthcare Commission from developing rates because by allowing the carriers continue to have single case agreements, they can then put pressure on practitioners to try to agree to some very low rate. And then we're going to have a problem because most people who are out of the network are out of the network because they can get reasonable rates. And so if we continue to have single case agreements where carriers are putting pressures on practitioners and practitioners can say, no, I have a full practice, I don't need to have some reduced rate, I think it's going to limit subscribers' ability to go out of the network. So thank you for hearing me.
Thank you. I'm going to call on the carriers to respond, but I will remind the committee that we do need to stop at 1:15. So, just so you know that we, please be concise in your remarks. So, Deb, you want to tackle it first? Deb Rifkin?
Sure. Thank you. I just wanted to, I know when I was listening to Delegate Saab, I went back and I looked at the language, which I think is what Dr. Berman was speaking to right now, which was, if I can read my screen, line 29 through 32.
Yes.
I really think Delegate Saab has a point there. All this language says, when I read it now, and I've had it for a very short period of time, like the rest of you, all it says is that we are required to inform a member that they can get assistance. It's just a notice. It doesn't mean they have to ever ask. It doesn't mean they have to use that opportunity. But if we're going to, so to me, I heard what David Cooney said, but this is not a substitute for saying, we'd like you to contact your carrier first so they can help you actually see if you can get to somebody in network for your service that you need. And if they're unsuccessful, then you can go out of network. And so I think he has a point there that language can be stronger. And if that's what the intent, it doesn't say it. But, we all should try to be, I think everyone, including the committee, legislatures would think that the best solution is to encourage people to stay in network if there is someone there. So why shouldn't we have that opportunity to help them first before they go out of network? So I'd ask that we can strengthen that language.
Okay, I'm going to go to Ms. Robinson, Kimberly Robinson.
Thank you again, Delegate Collison. So a couple of things. So one, Delegate Krebs sort of referred to it. We have a lot of concern with the idea that the state would rate set in this space. It would make Maryland's law completely unique from the rest of the country in this particular area, as opposed to this bill sort of conforming it to where part of the country is today, which arguably is ahead of other states. And there's a lot of pitfalls that come with rate setting, even with the examples where the state already has them. And so that rate, just as much as it might have the power to try to encourage, higher rates, it also has the power to encourage departure from the network because it becomes guaranteed reimbursement at that particular rate. And so we think that if there's going to be a compromise on how we move forward in this space, that what's been offered, which is, like I said, taken and derived from where the majority of states who've legislated in this area are, would be the best way to approach it. And as to the notice language, here's what our concern was there, in addition to the things that Ms. Rifkin just highlighted. One, that provision applies to all members and all services. It's not specific just to the area that this bill was focused on in behavioral and health and substance use. But for that reason, when we haven't started, as Ms. Rifkin suggested, with saying, if you're having trouble finding an appointment, call your carrier, and we jump immediately to your carrier's network is probably inadequate. Here's what you do to solve that. I think we are miscommunicating to members. I think we create anxiety in members, all members, for all specialties that doesn't necessarily need to exist. We know that sometimes what's happening is there's a lot of providers in the directory, and we don't necessarily expect patients to have to call everyone. We would rather that they pick up the phone and call us and let us assist them. Because if you call the first 3, you might not get an appointment. If you call the first 10, you might not get an appointment. But if you call the 20th, you might have, but nobody wants to go through that. And we understand that. So we want to be able to assist. And in addition, we know sometimes what's happening, what's being perceived and what's happening might be, they had an appointment available, but I couldn't attend on that date and that time. So it's not that they didn't meet the adequacy requirements or they couldn't give me an appointment if it didn't work for my schedule. That's equally frustrating to a consumer. And so we do think that it's important that the communication be about, 1, letting patients know they should reach out to their plan. 2, all of that notice about how this law works actually exists in plan documents already. So if that language had never gone in this bill, excuse me, in many of our plan documents, those at least that are approved by the MIA, their checklist already includes the references to 15840. The plan documents happen also not to be the most consumer-facing documents. If you're an employee plan, you don't even see the contract. That belongs to your employer. You're getting the certificate. And I would dare anybody on this call to tell me they've ever stopped to read their certificate of coverage personally to know what was in it, despite many disclosures and other language. There's much more consumer-facing places to put information like this. And frankly, the MIA is already requiring us around 15840. They will update it with the changes that are made to this law so that those documents are going to already reflect those changes, regardless of this language. We thought it was more important to encourage people to reach out to their carrier because that's what's actually lacking today. The rest of 15840 notification is not lacking today, and it won't be lacking once the MIA updates their checklist because it's what's required for us to get our plans approved.
Okay, thank you. All right, so we have just 8 minutes. So I'm going to go to Delegate Kelly first and then to Courtney and Ellen, and we will be seeing each other later today. Delegate Kelly.
Thank you, Madam Chairman, and I'll just be very specific and brief. I've been noodling through the idea of the Health Occupations Board's involvement, and I'm remembering the conversation. We sort of put a pin in this during COVID, but we have been having these conversations ongoing. I think that one of the challenges is number one, I don't think any of the boards currently have consent set up for the licensees to have their information shared. So that needs to be addressed. And number 2, there's some questions as to whether the information can be shared only with carriers as opposed to other groups who are looking for it as well. And they need clarification from the Attorney General and things like that. So my recommendation on sort of how to finesse the language would be something like a report back to HGO on progress towards this goal, by next year, so that the stakeholders can all get together and figure out the best way to get this done. That would be my recommendation.
Oh, thank you very much, Delegate. That's really helpful. Okay, Courtney.
Yes, I just wanted to touch on the notice requirements that were discussed as well. I have personally gone through this process with 2 different carriers, and I only actually found out about any rights within the law because an in-network provider who told me that I would not be able to find a in-network provider, most likely, that I had some rights to seek a single case agreement. So I do think it's really important to make that available to people in plain language. As Ms. Robinson said, people don't see their documents. I don't know if there's a way we could do this. If when people call, that's something that could be required. And if they're also regarding the Delegate Saab's point about asking people to show proof that they've called providers, I think most people who are in this situation have called numerous. And so I think if that were to at all be considered, there should be a maximum on the amount consumers have to call, because these requirements and procedures should already be in place.
I think what I heard from the carriers real quickly was that they would prefer, rather than the customer or the consumer calling 20 people, that they call the carriers first and say, I need help in finding, this service, who's available in your network, that's close to me. So not make those first 20 calls, but rather talk to the carrier. But that's the way I was interpreting the carriers. Ellen?
Thank you very much, Delegate Cullison. And again, thank you for the progress that's been made on this bill. We do appreciate it. Just two very quick comments. I would just like to reinforce the need to have, I think, probably both processes in place. The notice in plain language, which isn't already in law. So the in plain language is not in law. And that's what we hoped to add in order to make this information much more accessible to consumers. So having that right in place, as well as the call your carrier, those two pieces could work very well in tandem. So we would request that both pieces be put into place. And the second thing I wanted to mention is we notice obviously that there is a 3-year window. There is an expiration date on this, and want to ensure that we are gathering enough information in order to be able to evaluate it. We obviously we don't want this to be time limited. It is not time limited in other states. So if we are trying to model the language in the other 17 states, there is no time limit at all, no durational limit. So we really, we're not inclined to go in that direction. If that's the only way that we can move forward, I understand that. But we do need sufficient data to be able to understand what's going on. Thank you.
Okay, Delegate Kelly.
Sorry, my hand needs to come down. I'm good.
Oh, okay.
Sorry, my bad.
Right. So there are now 4 people who would like to speak, and we are essentially out of time. Again, I am so sorry. This is a factor of what happens at the end of or during crossover week. The schedules all get readjusted. I do want to spend a couple of minutes on, so we know we're going to come back after the Health Occupations and Long-Term Care Subcommittee this afternoon. I do want to touch on House Bill 974, physical therapy co-payments, co-insurance and deductibles. This is Delegate Kipke's bill. Lisa, real quick, can you tell us what it does and where we are right now with this bill?
So the original bill was going to require that co-pays and deductibles and co-insurance for physical therapy be the same as primary care. There are amendments in your packet that we're addressing that come up with some studied language for the Healthcare Commission on this. But it's my understanding that the stakeholders have talked and might be willing, instead of having a bill, to write a letter to the commission asking for a more general study.
Okay, so I'm going to go to, is Delegate Kipke here? I don't know that he is. Okay,
Pictures
so
on, but he's not there.
okay. So let me go to Matt Celentano.
Thank you, Madam Chair. The proponents of the bill had offered some study language a few days ago. And when we saw that language, we wanted to make sure that there was some additional study language from the carrier side to balance out and we think get to the heart of the issue, which we believe is the impact to premium, the actuarial value levels. And last night, that language that we had proposed that the MHCC had told us was fine was rejected by the proponents. Ms. Mercado and I and Mr. Shattuck, we all got on the phone this morning and they had said that maybe the best way forward was to just sit down with the MHCC and determine what the study should look like. And the idea came up of this sort of stripping all the study language, which I think is fine. But then I thought about it a little bit after that conversation and figured, well, if there is no language to really focus in on, and we're going to have the MHCC look at this with the consultation of stakeholders, we don't really need a bill. All we would sort of need would be a chairman's letter to sit down. And I think we would be more than happy to work with stakeholders in the summer to find out what the impact of this kind of approach would be.
Okay, Mr. Shattuck, Dan Shattuck, you want to respond?
Yeah, so we did have a conversation with Matt this morning. Our language that he was referring to was, instead of specifying the details of the study, let's have more generalized language, but we were still intent on keeping a bill, leaving the particulars of what to be studied in the context of copays and cost sharing and things like that. Sit down after the session under the auspices of the bill to hammer out the specific details. And then there were still provisions that we thought worthy of like a literature review looking at the opioid impact and so forth. So the chairman's letter is a new twist. And as Matt said, it was after our conversation, but anyway, we're still suggesting we move forward with the bill, just making the study language a little less specific and let that be determined, through discussion with the Healthcare Commission and the other stakeholders that want to be involved as well.
So I guess I'm going to push back a little bit in terms of what is it? Well, I'm going to actually, no, I'm not going to ask because Mr. Stefan is here. So Mr. Stefan, speak to me about your considerations of this.
Thank you, Chair Cullison. So under the insurance article 1501, the commission was given broad authority to evaluate the impact of mandates, specifically those that had passed, which are seldom done, and those that had failed but were expected to reappear. The statute speaks broadly along three dimensions: social, medical, and financial impacts, which I think from what I'm hearing would largely cover the parameters that both the advocates and the carriers would be talking about. And we'd be happy to sit down if it's the preference of the committee to develop a study, and it could be facilitated by a letter at the conclusion of this meeting of the minds. But I think we could meet that within the existing law. I will say that since the passage of the ACA, that has not been invoked as commonly because of limitations on state mandates on insurance products in the individual and small group market. So happy to help on this one if it's the will of the committee.
Thank you very much, Ben. Barbara Mercado.
Thank you, Madam Chairman, members of the committee. This takes us a little by surprise, and we had many discussions with our client, and they are very invested in really trying to look at the barriers that these co-pays have on the subscribers. Yes, we need to look at the premium increases, but I hear you, Madam Chair, but I think the strength of the bill that really holds firm that this is going to be a serious study, this is a very serious issue, sends a message. if it is the will of the committee that we're not going to pass a bill, I do know that our client stands ready to really roll up their sleeves. We've even in testimony had researchers. You'll see in the amendments to the study, our client has already looked at literature that is important to review. So it is the context of the importance of this issue in terms of prevention, the opioid crisis, that I would ask serious consideration of going ahead and passing it in legislation.
Okay, thank you, Barbara. I know, and I'm going to throw this out to the committee now. We've had a number of instances where we've asked the MHCC to do a study for us, and I feel like they have done extraordinary work, and they've come back with us with information that we were able to use in future legislation. So while I appreciate the import that a bill might provide, I think at least in a public sense, I think the work can be done. This is my opinion, and I'll look to the committee to see if we have a motion, that we can accomplish the goal of this study by a letter from our chair, who will explain how important this is, and we will expect a full report at the next session. So do I have any motions from the committee?
To move for a letter for the chair, is that what you're asking for?
I was asking for that, Madam.
I just want to make sure, because I don't know that we move for a letter for the chair, but suggested. I don't think we need to vote on it, but I think the letter for a chair plan is a great plan. I've seen it work many, many times in the past. I think it's a good approach.
Delegate Saab.
Just a quick question. So it's turning into a study, just the
Yes.
physical therapists?
My understanding is that the advocates had contacted other rehabilitative services, so that there would be some engagement around that as
So
well.
it's not just one, so,
Not just one, right?
okay. So we don't know what
Yeah.
we were studying yet.
Right. Well, we have ideas, given,
Right.
if you look at the amendments, a lot of that, framework will be included in the letter, but, we don't know exactly. Barbara?
Thank you.
I
Thank
just
you.
want to make sure that everyone on this Zoom knows that I have the utmost respect for Mr. Steffen and the commission, and have had the pleasure of working with him almost since the commission was established when John Comer's his predecessor. So there's never a question about the level of commitment and quality of the work that the commission undertakes.
Thank you, Barbara. I really appreciate that. And I echo your sentiments. Okay, with that, we will ask the chair to write a letter that will create the motivation for this study. And I know that MHCC will be working with the stakeholders on this. With that, we need to adjourn or recess this subcommittee and reconvene after the health, about 15 minutes after the health, occupations, and long-term care committee this afternoon. Thank you all, and we will see the NCHO bill hearings begin in 8 minutes. I know. We will see some of you then. Take care. Thank you.